Welcome, everyone. My name is Wendy Singer. I'm just going to get organized here for one moment. Okay. Welcome, everybody, to No Shame on You's monthly Feed Your Mind series, Treatment-Resistant Depression, Unlocking New Avenues for Healing. I'm Wendy Singer, as I mentioned, Executive Director for No Shame on You. And on behalf of our board of directors, staff, and volunteers, we welcome you to today's program. No Shame on You is dedicated to eliminating the stigma associated with mental health conditions so people who need the help will seek it and family and friends will know how to support others and to ultimately save lives. We achieve our mission through all sorts of programming, virtual programming like you're seeing today, in-person programming, an online presence of over 120,000 social media followers on different platforms. We have a blog, podcasts, distribution of resources, crisis information, and we customize presentations in the mental health realm for all sizes, all audience sizes and types of organizations. We partner with organizations throughout the Chicagoland community and country and are known for our inclusive, consistent, and responsive programming for people of all ages. And now for a little housekeeping. Following the presentation, we will have a Q&A for a few minutes. You can submit your questions directly to me, Wendy Singer. And now I want to introduce our wonderful speaker that we're so honored to have today. I want to welcome Dr. Chris Anandappa, who is the attending psychiatrist at SunCloud Health and clinical director of its interventional psychiatry program. He completed his medical training at the University of Illinois College of Medicine with residency at the University of Michigan, followed by a fellowship in forensic psychiatry. Dr. Anandappa has had extensive experience across various levels of psychiatric care and is a board certified adult, adolescent, and in forensic psychiatry. He is also a fellow of the American Psychiatric Association. I ask, if you are listening and not asking a question at the moment, please turn your microphone on to mute to avoid feedback. And without further ado, I would like to welcome Dr. Anandappa and his colleague, who he will introduce.
Thank you so much, Wendy. I'm joined here by my senior interventional technician, Anthony Mio. Anthony has been working with me over the last few years here at SunCloud Health, helping get our interventional program started. And he is sort of our chief cook and bottle washer, who helps both with the administration of treatments, but also with some of our prior authorization and just as an overall man about town getting our things done. So I wouldn't have been able to do the things we've been doing here without his help. So Anthony will be joining in as well. So without further ado, let me go ahead and share my screen here, and I will pull up my slide deck using good old PowerPoint here. As Wendy said before, if we could save questions near the end, I'll definitely keep an eye on time here and try to make sure we have enough time for that. Hopefully I will answer some of the questions that come to mind during the talk, but we can definitely review some of those things when we're done. Alrighty, and so as she had mentioned, what we're doing with treatment-resistant depression is unlocking the new avenues of health. And so as a quick bit of housekeeping here, just to say, first, I've got nothing to disclose. It's a standard thing that most doctors do when they give a talk here. I work for SunCloud Health. We do provide interventional psychiatry services, but I'm not in any cahoots with any drug or instrument manufacturer at this time. Also, as I like to say, my second slide is, I don't think of myself as an expert in treatment-resistant depression. I always say I'm mostly a clinical psychiatrist. I treat patients in our residences, in our partial hospitalization and intensive outpatient programming. But then I also, for the last few years, have been working in the interventional area of care. So what I hope to do is answer most questions for a non-psychiatric audience. So with that, here's an outline of our presentation today. First, what is treatment-resistant depression, and what is the relationship with quote-unquote interventional psychiatry? Second, what is neuromodulation? And that includes the technology known as transcranial magnetic stimulation, or TMS. And where are things at right now? Third, what are some current and future psychoactive treatments? And what are the possibilities for depression treatment? Fourth, we'll be addressing some controversies and challenges with these advanced options. And then lastly, time for question and answers. So without further ado, let's have a review here, right? Most of us have heard of what we call major depressive disorder. It's common, costly, and disabling. Well, here in the United States, MDD has a 12-month prevalence, about 10% of the population, and a lifetime prevalence of about 21%. The estimated direct and indirect costs, no surprise, over $200 billion annually. And worldwide, major depression is a leading cause of disability. It often predicts a decrease in role functioning, and that can manifest as low earnings, poor work performance, difficulties in marital relationships, and of course, some strong affiliation with physical illness as well. Cardiovascular disease and stroke, chronic fatigue syndrome, fibromyalgia, and things like irritable bowel syndrome, or IBS. Now, for a lot of the folks out there who are somewhat savvy to mental health things, when we talk about treatment-resistant depression, we have to first talk about depression. And as you can see here, it includes so many of these symptoms here. Feeling broken, feeling angry, feeling sadness, loneliness, helplessness, feeling grief or prolonged grief, even beyond the loss of a person or a change in one's life. Some people feel an apathy, which is described as a nothingness. And then, of course, some of the big ones here, senses of hopelessness and helplessness, and also that pure feeling of being empty. But for more specific reasons, when we say what is TRD, it's characterized by the lack of symptom improvement despite treatment with a minimum of 2 different courses of antidepressants. After a patient fails 2 antidepressants, research shows that they will likely fail subsequent traditional antidepressants. And depression comes in major types. About 1/3 of people we might call major depressive disorder. And of those, about 1/3 will have treatment-resistant depression. But on top of that, let's look at some of these other domains that a TRD person might experience. Functional impairment, co-occurring physical symptoms. Of those, we see a lot of fatigue, headaches, a lot of somatic symptoms. It can be persistent, it can be recurrent, and of concern to a lot of people out there, it can be accompanied by suicidal thoughts, one of the more concerning aspects of any depression, but especially with TRD. So what are the initial options for treatment-resistant depression? Well, here's a list of what we know are the main options, but it should come as no surprise. The first step usually is antidepressants. And as you can see, I've listed a number of the different antidepressants out there. For most people, it will involve something like an SSRI or an SNRI, and they have names like Cymbalta or duloxetine. I know a lot of you folks, if you're old enough, might have heard of some of the tricyclics, and we have names like Elavil and Anafranil and Tofranil and Pamelor down here, you can see. With the MAOIs, or monoamine oxidase inhibitors, we don't see those a lot because of certain concerns for side effects. But with some of the newer combinations, you might have heard those names as well. Remeron, Deseril, Wellbutrin are all very popular medications. But when those initial medicines don't work, we're often augmenting with several different products. The most common about 30 years ago included the mood stabilizer lithium and T3, which is known as thyroid hormone. More recently, we've started to see antipsychotics, and they have names like Abilify, or you might have seen commercials on television for Rexulti and a few other medications. Now, an important thing to realize is the time frame of TRD medications, and we'll circle back on this a little bit later as well. So antidepressants, most of the time, we're looking at a period of about 2 to 6 weeks for maximal antidepressant efficacy, but it might be up to 12 weeks before somebody really notices something. What the evidence has shown is oftentimes older people will take a longer amount of time to show response to antidepressants. Early switching to another agent may not benefit a patient more than waiting, so oftentimes a conservative approach is to wait anywhere from 4 to 6 weeks and then gradually titrate up the dose of that medication. No drug is proven to take full effect faster than another, but some symptoms may improve in the first few weeks, even though depression signs might be there. Now, I mentioned before, other medications like what we call atypical antipsychotics are often added to augment the maximum dose of those antidepressants. That too might take days to weeks to show benefits, especially in treatment refractory depression. One of the older augmentators, lithium and T3. Lithium might take 7 to 14 days for onset and maximal efficacy in about a month. And then with T3 hormone, we started at a low dose, about 25 micrograms, and then increased that over 2 to 4 weeks. So even when antidepressants don't work or switching antidepressants don't work, we're still going to augment them with medications. Now, what is interventional psychiatry? A brand new term that's been used, and I myself only started using it about 2 or 3 years ago. Well, there's a book that just got published, and you can find it here on Amazon. And I thought, maybe the best way to introduce it is just use what they have in the Amazon description, which basically says, recent advances in pharmacology and brain stimulation have led to the development of novel treatments for psychiatric disorders. These new advances have led to the development of a new psychiatric specialty, interventional psychiatry. This text reviews all the specialized treatments, including device-based interventions such as electroconvulsive therapy, repetitive transcranial magnetic stimulation, and deep brain stimulation. It also discusses procedure-based pharmacologic interventions, including ketamine infusion therapy and psychedelic therapy. So that says in a nutshell what we're going to be talking about today. And again, when we were talking about these options for TRD, you can see they're right underneath those medication suggestions. Underneath that as well, you can see some recommendations for supplements, but these, even though there's a lot of evidence suggesting these things can be helpful, and definitely they're not hurtful to anybody, there's definitely some question as to the extent of benefit one can have with them. But nevertheless, they are reasonable options as well. So along that lines with what is interventional psychiatry, I like to say some of these things are older things. Now, I'm sure many of you have heard of what is commonly known as quote unquote shock therapy, or we say in psychiatry, electroconvulsive therapy. But I'm sure some of you have also seen some of the less than savory aspects of it. This is, of course, Jack Nicholson as McMurphy in the famous film One Flew Over the Cuckoo's Nest, receiving electroconvulsive therapy, but in a fashion that is not done today. Most patients who receive ECT are given anesthesia, so they're put to sleep for that, and they also have their muscles sedated by an agent called succinylcholine, so they're not flopping around with having a physical seizure. So it's much more humane and much more reasonable treatment. And then it also includes some newer things. And those are what we'll be spending a lot of time talking about, Spravato or esketamine, a type of ketamine, as well as, you can see the little machine there, transcranial magnetic stimulation. That's a picture of the device that we use. So our next section here is called What is Neuromodulation, including TMS, and where things are at right now. And this picture has just a summary of several different types of neuromodulation that have been evolving over the last several years. So what is neuromodulation? Well, I point to an article in Current Psychiatry from June of 2023, and they look back at the origins. And this I find fascinating. In 46 AD, electrical modulation was introduced by Scribonius Largus, a physician in the court of the Emperor Tiberius, who used torpedoes, which is most likely electric eels. And you can see we've got one here biting an individual and measuring the response with an ammeter. Believe it or not, they used to use this to treat headaches and other pain from arthritis. Usually, loosely, these clinicians were moderating human function using electricity. Now, fast forward to the late 1800s, electrotherapeutics was a growing branch of medicine with its own national organization, the American Electrotherapeutic Association. But in that area, electricity was very novel, powerful, and seen as the future. Now, because some of those novel therapeutics were offered both by mainstream doctors and dubious sources like quacks, many of those products that were marketed with the promise of curing everything from cancer to headaches. And I think if I recall in the movie The Road to Wellville, which is about Dr. John Harvey Kellogg and and the Battle Creek Sanitarium, they were doing something where people were having electrical currents pass through water, which we know is going to cause electrocution, but still just a great representation of how a lot of really interesting ideas were explored. Nevertheless, the use of electrical currents to try and change difficulties in the brain were first noted at that time, and the roots of that experience is still what we use today. Now, modern electrical neuromodulation began in the 1930s, obviously with electroconvulsive therapy, and that was followed by deep brain stimulation and then spinal cord stimulation in the 1960s. Often a lot of that is used to treat neurological and not necessarily psychiatric conditions. Target-specific, non-invasive brain stimulation became possible when Anthony Barker and his team developed the first device that permitted transcranial magnetic stimulation way back in 1985. So again, looking at neuromodulation, let's summarize some of the thoughts on therapeutic neuromodulation. And I'll start with some of the older ones here. So with deep brain stimulation, now this provides an invasive, if you will, a functional neurosurgical procedure that uses the current directly to modulate specific areas of the central nervous system. And that's an example of it there, if you guys can see that picture. It's used in depression, but also Parkinson's disease and muscle dystonia, as well as things, and I've seen this actually in someone who had a device implanted at University of Chicago Hospital with really severe obsessive compulsive disorder. In addition to that, techniques, including magnetic seizure therapy, which kind of looks like this. That's an intense high-frequency magnetic pulse sufficient enough to induce a seizure. So it's a little bit like ECT, but you use a magnet as opposed to a direct current. And that too is being used for depression. With vagus nerve stimulation, this is something I'm modestly familiar with. Again, we used to do that at the University of Michigan, where I trained in residency. And that's intermittent mild electrical pulses delivered, of all places, to the left vagus nerve, one of the cranial nerves. And then those afferent fibers affect such structures, such as the locus coeruleus and the raphe nucleus in the brain, which have been linked to the experience of depression symptoms. That it can also benefit for people with epilepsy as well. But what we're going to be focusing on a lot today is this, transcranial magnetic stimulation. Right now we use that for depression, obsessive compulsive disorder. It's approved for substance use disorders like smoking cessation, but we're seeing it used more for migraines, post-traumatic stress, and even things such as tinnitus, right? That ringing in the ears. That too, we
Make it a little louder. I can't hear with the coffee.
Oh, sorry about that. Well, let's move on. So when it comes to choosing a neuromodulation, I think this is a very important question. As I said before, some of these things are invasive, as you can see here, and some are non-invasive. Now, with the non-invasive options, something like electroconvulsive therapy has been around. It's proven safe and effective for a number of different conditions, and you see rapid improvement over the span of about 2 to 4 weeks. But there's acute cognitive effects that might limit the ability to work and drive and handle daily activities. And there's a risk for memory impairment, which is usually short-term memory before and after the procedure. As you can imagine, things like vagus nerve and deep brain stimulation have certain pros, such as very useful in a strongly treatment-resistant population, and also vagus nerve is good in patients who respond to ECT. However, that too has its cons, surgical risks, such as problems with dysphagia and dysphonia, because some of the cranial nerves are adjacent to the nerves that power our speech and vocal cords. And then also issues with long duration of treatment, and it's not covered yet by most insurance. Deep brain stimulation, again, very useful for different patients, but a long duration of treatment, and then it's very expensive, invasive, and only available at very, very specialized centers. So something that you're not going to see in an outpatient clinic. Again, taking us to transcranial magnetic stimulation, we can see that it has a number of different pros here that we'll talk about, and only a small risk for seizures as well. Now, I like to point this slide out, looking at ECT versus TMS, and you can see that there's a lot of benefits for TMS that maybe outweigh some for ECT. In terms of the stimulation pattern, the ECT treatment sends a signal to the diffuse parts of the brain, whereas TMS is very targeted. Cognitive patterns Obviously, ECT can be very substantial with short-term memory loss, but TMS, almost no patients have ever reported problems with memory afterwards. And of course, ECT is a little bit more complicated. So there, we have to use anesthesia and muscle management to decrease convulsions or discomfort, and none of that is required in TMS. So at the same time that we think right now, well, is TMS going to replace ECT? Well, at the same time, I think that there are some benefits for ECT that we should consider as well. Now, you can see here that with rapidity of onset in terms of treatment time, ECT, a person can start feeling a response, meaning an increase in their or a decrease in their depression symptoms within about 2 to 3 weeks. But the treatment schedule also is a little bit less at about 3 times a week. TMS, on the other hand, does require daily treatment. That's Monday through Friday, and sometimes as many as 7.5 weeks. And as you can see here, it might take a full 2 to 3 weeks of TMS sessions before the onset. In other words, ECT is more intense, may work faster, and have a shorter time of treatment onset, but TMS is less complicated, less invasive, and has fewer side effects. So I think for the vast majority of population right now, when we say, well, in the battle between ECT and TMS, I think we're looking at TMS. So with that, let me show you this little video here of what it may look like, starring our very own Anthony Mio.
Should it have sound, doctor?
You know, it should have some sound, but unfortunately, I think depending on how the person is accessing it, you know, it's a YouTube clip here.
No
So,
problem. No
but it's
problem.
yeah, no worries.
It gives a
But no,
visual, which is important.
no worries, no worries. And that's what you saw here was Anthony using our TMS machine, which is made by MagStim, and treating actually our Director of Operations, Melissa, in those pictures there. But with that, let me just tell you a little bit about this. So one of the questions you guys probably have is, how does transcranial magnetic stimulation work? Well, what we do here is that a TMS device generates a perpendicular magnetic field that penetrates the skull and brain tissue, and it's induced by 2 coils of metal wire that carry an electrical current. Now, as you can imagine, right here at the nexus of both of these coils is the actual signal. And as that signal is applied to the surface of the head, it starts sending an electrical field by that magnetic action. Now, while that's being done, there's a very powerful computer that rapidly switches the magnetic field on and off, inducing another electrical current that stimulates the neurons in that part of the brain. Now, by moving the device, we can focus the stimulation on the brain regions that are involved in depression. Most of the time, that'll include a part of the brain right here, the left dorsolateral prefrontal cortex. Now, we do have 2 types of TMS devices, and I wanted to talk about that briefly here. What we use here at SunCloud is our TMS, and we use a device made by MagStim, something a little bit newer than this, but very similar. Now, it does have a technology that allows for the placement of that figure 8 coil. We use an electroencephalograph to kind of identify where the best motor area is, and then from there calculate a spot 5.5 centimeters in front of that where we'll actually be treating you. We use this for major depressive disorder and obsessive compulsive disorder. We'll talk about how we use it in a super short program, but it's nevertheless very useful, called Beta Burst, and also doing a new program they made at Stanford University called SNT. Now, with the other technology, the BrainsWay device, this is currently FDA approved for 3 different diagnoses: major depression, obsessive compulsive disorder, and smoking cessation. And as a result, it uses 3 different helmets, and you can see the different coils that are embedded in these different helmets. The H1 coil in that helmet is used for major depressive disorder, again, treating that bilateral prefrontal cortex. The H7 helmet we use for obsessive compulsive disorder in the anterior cingulate cortex and the medial prefrontal cortex. And then the H4 helmet is used for smoking cessation. That's attaches to an area called the bilateral insula and near the prefrontal cortex as well. So really going to talk about a little bit more about the MagStim device, but I want to make sure that there's no bias in my talk today. So if you learn more about these and are introduced to either one of these technologies, both of them are FDA approved and can be very, very helpful. So prior to getting TMS, there's a number of different things that we do, and patient has to be screened, and we have to go through some preparatory questions. Now, as we try to do, explain the basic mechanism of TMS, the treatment timeline, what the motor threshold procedure is, trying to find out the minimum amount of energy that we need, which is always dependent on the person and the unique qualities of their brain. And then, of course, potential risks and how they're mitigated. For that, we go through what's called the TMS Adult Safety Screen, or the TAS. And as you can see here, we review a number of different concerns, anything for advanced reactions, a history of seizure disorder, any kind of problems with EEGs, any kind of head injury or stroke, and most importantly, do you have any metal in your head, such as shrapnel, surgical clips, or fragments, or things like that. Also, what we're going to ask you is some questions about how you've been doing and things that could affect the quality of the TMS treatment, such as how much sleep did you have the night before? Have you had any medications by your doctor? Of note, when it comes to side effects, the main side effect that we look at for TMS is headache. But we can talk about that in a little bit because it's often very transient. In the last few years, we've actually seen patients really acclimate very well to the unique tapping of the TMS treatment. But likewise, there can be a few other things, some psychiatric responses, hearing changes, or hearing that tinnitus ringing in the ears, and in very, very rare cases, somebody feeling faint or maybe possibly having a seizure.
We also ask them to minimize their caffeine use.
Yes, thank you. Very true, very true. Things like caffeine, lack of sleep, medication changes can all affect the quality of your brain function. And so what we like to do is minimize anything that can affect that. So let's check prior to receiving TMS. We want to make sure that any kind of jewelry, especially on the left side of the face, is minimized. You have people with different kinds of skin piercings and nasal piercings. But Anthony, so far we've done pretty good, right, with people with earrings and ear.
Yeah, the only
jewelry.
thing, if they have like something in their eyebrow, that's getting a little too close.
Yeah.
But even nose rings and earrings, we haven't had any issues. And they say it's not like it's gonna fly off the person and stick to the magnet. It's more of an issue where it's gonna induct and heat up.
Exactly.
So bobby pins you have to watch for and that sort of thing for the most part. But yeah, as long as there's enough distance, you should be good.
For sure. What we've started to do about a year and a half ago is offer patients some hearing protection. The machine, after all, can get a little loud and it makes a tapping sound. So patients will usually wear a disposable ear protection for that. Likewise, because the main side effect is headache, a lot of the time we'll ask our patients to take a non-steroidal anti-inflammatory of their choice, either like ibuprofen or Tylenol. Strangely enough, the vast majority of patients may do that for the first week or two, but as they continue with treatment, they find they've acclimated pretty well. They don't need that anymore. So one of the other things that we will often do, or at least every week, is use a statistical tool to measure that person's depression symptoms. As I said before, what we do with a TMS device usually lasts about 7.5 weeks, Monday through Friday. And so every week we will ask a patient to rate elements of their depression here using the PHQ-9 scale. And we'll track that as we move forward to see if we have a response. Now, here's a brief little video of a patient receiving TMS treatment. I hope some of you can hear it, but it's very short, so maybe if you can, you'll just bear with us here, all right? Hold on, please.
Doctor, real quick, if
Yep.
you stop sharing and reshare, there's a button that says share sound on the bottom, and then we'll all be able to hear it. Thank you so much.
Share, and then share sound, is that under audio or?
It should, when you hit share screen, on the
Mhm.
very bottom left, there's a little round square that says share sound.
Okay, here we go, share sound. Very good. Thank you so much, Wendy.
Of course.
Wonderful. Thank you. So let's pop back to that here. And then let's give this a try. Right.
Guard getting her treatment. All right, so this is Dr. Bonakdar getting her treatment. How do you feel, Dr. Bonakdar?
So this is the first time I'm having this treatment done, and it feels just fine. And it's not painful. It's very
Excellent.
comfortable.
Excellent. So this is her first TMS session. We're doing a theta burst protocol. We've got the target set, and there's no discomfort so far. Hopefully there won't be ever, which we don't expect. She's doing great. And we're on our way to brain rejuvenation. All right,
Woohoo!
great.
Awesome. I hope most of you were able to hear that. That was a slightly different technology than we use, a slightly different machine. But as you can see, very non-invasive. The patient is awake, not in any kind of major discomfort or anything like that. So very, very good example there. So when we talk about the TMS options for treatment-resistant depression, I think it's important to talk about what some of that looks like. And so I had alluded to a few things, both intermittent theta burst, which is what they were doing in that little clip there, but also the SAINT, or the Stanford Neuromodulation Treatment Protocol, using RTMS. And basically what that breaks down to is, with the theta burst protocol, it's a very short, lasts about 3.5 minutes. And the way it's normally done without that SAINT protocol is about 600 pulses per session, 1 session a day. Again, 36 sessions, usually of about 7.5 weeks. But with the SAINT protocol, what the clever people at Stanford University had figured out is that if they did 10 sessions a day of the theta burst, so from first thing in the morning till about 5 or 6 at night, 3 minutes of treatment with about 50 minutes in between. So a fairly long day, between 9 and 10 hours. Again, 50 minutes between sessions over 5 days a week. But with those 50 session total in 1 week, what the evidence found was surprising. A double-blinded randomized control trial showed that 79% of the patients had a depression remission rate in the 4 weeks after treatment, compared to 13.3% in placebo group. Now, you guys might have remembered that initial slide that said some folks will have to wait 4 weeks, 8 weeks, 12 weeks, or longer to respond to oral medication. What the folks at Stanford were saying is that if you went through this intensive treatment, I know that's a lot, that might last a good part of the day, but in 5 weekdays, you could actually have 80% of people have their depression in remission. So it's very exciting to see what the future of neuromodulation has compared to where we've been at for so many years with regular medication treatment. Now, with that, let's pivot and talk about some current and future psychoactive agents and what are the possibilities for depression treatment. And you can see here it's a great graphic of someone who looks like they're using some psilocybin or magic mushrooms, but they're doing that with the therapist. So with current and future psychoactive agents, I'm sure some of you have heard of this man and his book, How to Change Your Mind, What the New Science of Psychedelics Teaches Us About Consciousness, Dying, Addiction, Depression, and Transcendence, by none other than Michael Pollan. In the intro of his book, Pollan mentioned some of the psychedelics that were first introduced to America and the world, including LSD, or lysergic acid diethylamide, as well as psilocybin, otherwise known as magic mushrooms. Now, here's a list of a lot of the classic and non-classic psychedelics broken down by the type of family that they incur. Now, the top one you can see are called tryptamines, and then here at the bottom are called phenylethylamines, and that does refer to some aspect of their chemical structure. I'll leave that to the chemical engineers out there. But you can see a lot of them have a lot of interesting uses in treatment. LSD, for example, we remember Timothy Leary talking about dropping in and dropping out during the 1960s. But there's been evidence to show that LSD could be very dynamic in the treatment of depression, anxiety, as well as substance use disorders, including alcohol use. Psilocybin, or magic mushrooms, which are a natural agent that have been around for a long time, has a number of different uses: depression, anxiety, even treating other substance use disorders. And it's been helpful for people with illness-related anxiety, cancer treatment, depression, and a few other things as well. You've probably heard of ayahuasca. I'm not really going to talk about that as much since that's a little bit more complicated. But other drugs you've probably heard of is peyote, sometimes used in certain ritualized religious ceremonies with indigenous groups. That has been found to be helpful in substance use disorders. And then MDMA, otherwise known as ecstasy, which is a frequently used party drug if people went to raves and things like that. Some of the altered consciousness that it can provide has actually been shown to be helpful in people with PTSD, and we'll talk about that as well. Now, what do psychoactive agents do? Well, hallucinogens, right, for the most part, will distort perception, and they affect the functions like listed here: hearing, thinking, feeling or emotional state, seeing and visual acuity, as well as things as olfactory sensation and smelling as well. Now, inasmuch as that these medicines work in a much more dynamic fashion than those medicines I listed before, the typical antidepressants, one of the big differences is that hallucinogens can be psychologically addictive. And we've known that for a number of years. And here at SunCloud, when we treat addiction, we see some people who definitely develop a dependency as well. Now, with classic versus dissociative hallucinogens, I think this is a really important breakdown here. We're looking at classic hallucinogens, and you can see those here. Good old LSD on a little stamp there, psilocybin mushrooms, DMT, which is available in one of those earlier products, and of course mescaline, which occurs in natural products as well. Now, they cause visual distortions and altered sensing lasting about 6 to 12 hours. On the same token, dissociative halogens, right? And that includes things like what we're going to focus on here, ketamine, includes some other products that we might see as well. Dextromethorphan, which is commonly used in Robitussin as a cough suppressant. Then, of course, more dangerous substances like when people misuse nitrous oxide or the street drug PCP. That causes detachment from reality and altered senses lasting 1 to 4 hours. But one of the things that we got to think about here is that with that detachment from reality, how can that help in a therapeutic context? Well, let's talk about ketamines. So with S-ketamine, we can see that it has an effect on a wide range of substances and activities. Oh, but let's talk about its history first. Now, ketamine is a 57-year-old compound. It was used during the Vietnam era as a combat anesthetic, and then by the 1980s, elements were sent off the clinical world and used as a club drug. But by 1964, we found ketamine to be a safe, short-acting anesthetic with almost analgesic properties, but in some cases could cause delirium and dissociation. Now, as I said, the abuse of ketamine, they call it cat Valium because I think a lot of the ketamine that finds itself in street use is stolen from veterinary clinics. It can cause psychosis, induce seizures, and cause urinary tract problems such as ulcerative cystitis. Initially, when it's used as a pain management or anesthetic, we use a dosing of about between 0.1 to 0.5 milligrams per kilogram. And the first couple randomized control trials showed for depression that it was really helpful. So not enough to provide anesthesia, but definitely enough to cause changes to one's depression symptoms. Lower doses have been trialed, especially with the S-ketamine product. In general, antidepressant effectiveness of ketamine was demonstrated in all the studies, regardless of the dose. Last but not least, ketamine treatment using IVs has been in Chicagoland since at least 2016, most of the time not covered by insurance. And then by March 4th of 2019, the FDA approved S-ketamine. We'll be using the brand name Spravato as well for depression treatment, which has been a game changer since that is covered by insurance. Now, when you look at ketamine versus S-ketamine, what are we looking at here? Well, ketamine is a combination of both the S and the R, the right and the left-handed versions of ketamine together. We call that a racemic mix. So when you look at ketamine infusion therapy, and you can see the bottle that might be utilized if you go to an infusion clinic, that's going to be the combined version of both right and left-handed molecules. whereas Spravato is just going to be the S-ketamine version. And with Spravato, you can see here, this is not administered intravenously, but intranasally. Now, how do the ketamines work? Well, this giant table here you can see lists a number of different systems in which the ketamine system operates. It's got antidepressant effects. It's got antidepressant effects that overlap with your standard antidepressants, but it also works on muscarinic receptors. That's why it can cause an increase in blood pressure and heart rate, as well as this new category called sigma-1 and sigma-2 receptors that have antidepressant and cardiac effects as well. Again, the intravenous rate has 100% bioavailability, and it's infused twice a week for 2 weeks. The intranasal route is not bad either. It's administered in these doses of 56 to 84 milligrams twice a week for 4 weeks. Now, with the diagnosis-based dosing of esketamine or Spravato, we follow a very simple template. So if you have major depressive disorder, we'll start the first dose at 56 milligrams and do that twice a week for the first week 1 through 4. We might increase that to 84 milligrams if we need to, especially during weeks 5 through 8. And then weeks 9 and beyond, we'll just do it once a week, or once every other week, I'm sorry. When we do it for major depression with suicidal ideation, we actually flip the administration. So we'll actually start that at the higher dose, 84 milligrams twice a week, and then we might gradually bring that down to 56 milligrams based on the tolerability to the patient. Now, with the logistics and planning for esketamine, there's several parts to it here. Medication is intended for use in conjunction with an oral antidepressant, and you must monitor the patient for at least 2 hours after administration because of the risk of sedation and dissociation. That's why the FDA has it under a risk evaluation and mitigation strategy, or REMS. Now, with REMS, what does it involve? A patient has to be enrolled in this. As part of REMS, we have to follow certain rules and requirements. It has to be received in a healthcare setting, so you can't receive it at home. It's self-administered by the patient, but under the direct administration of the healthcare provider. The patient is monitored for at least 2 hours and no driving until they get a good night's sleep. That's one of the hard and fast rules of receiving Spravato. I know a lot of people feel like they're able to drive, but that's the rules. Also, we must send a monitoring report to the REMS after every dose administration. So every patient at every dose has these forms completed. And as you can see here, it talks about the date, the dose, the blood pressure monitoring, issues of side effects such as sedation, dissociation, and even if there's a serious adverse event, the REMS system wants to know. And that's for every patient on every time. We have a basic check prior to Spravato scheduling, and it's pretty straightforward, confirming the diagnosis, checking the amount of antidepressant trials, making sure that prior authorization, or we call that PA, is received from the insurance company, reviewing the guidelines again, signing the consents for treatment, figure out the timing and delivery. And then once all that registration is set, we build a schedule for you, build a reminder phone calls, arrange transportation. Again, you're going to need a ride back home. And then sometimes even screen for other things as well, for drugs and pregnancy as well. Again, we will check vital signs prior to and after Spravato. Sometimes if your vital signs are too high, so your blood pressure over 140 systolic, we might ask you to return another day or see your PCP for some medicine to help control your blood pressure. Likewise, we keep an eye on your oxygen concentration to make sure it doesn't go too low. Now, on the day of administration, we ask people to hold food 2 hours before and liquids 30 minutes prior, just so that we don't interfere with the absorptive surface. If you take a nasal agent, take that an hour before, because we don't want any other chemicals interfering with that. I'm going to summarize this really quickly here just for the sake of time. You can see that you blow your nose, make sure nothing's there. You take the device in your hand here, you tilt your head about 45 degrees, and then you enter it into your nostril. You press down once until it stops. You sort of sniff gently, and then you take it again and you put it in the other nostril, repeat it as well, press down, and it's administered. Now, after that first device is administered, you want to wait 5 minutes, again in a comfortable reclined position, and you don't want to blow your nose. The 56 milligram dose is 2 of those devices, and the 84 milligram dose is 3 of them. Pretty straightforward. And as you can see here, we have to dispose of it because ketamine is considered a Schedule III drug. So obviously there are concerns with drug abuse and the side effect profile here. Patients may have a variety of symptoms, including anxiety, dysphoria, disorientation. If they're severe, we might pause or stop that. What we do at SunCloud is we actually use the CAD-6, which is a tool here you can see, to monitor dissociative symptoms on a regular basis, just to make sure we're being thorough with that. Now, with that, let me quickly go to some controversies and challenges with these advanced TRD options. This is a new copy of the Practice of Electroconvulsive Therapy that just was released a few days ago. As I said before, we know what ECT suggests is the infamous picture of the shock therapy here. But then also, most of you heard about a year ago, I think it was October 28th, when the actor Matthew Perry from Friends was found deceased as a result of a ketamine overdose. Here's a picture of what's the lady they call the ketamine queen who provided him with some of that. Now, let's start with TMS and neuromodulation. So with TMS tolerability and side effects, it's actually pretty good, but some observations have that the site pain in TMS might be a little difficult. It might be uncomfortable for people, right? You know, that tapping of the brain, I describe it as like the woodpecker going. And patients with chronic headache might tolerate TMS to a lesser degree. Likewise, with pain mitigation, we use over-the-counter meds like NSAIDs, Tylenol, ibuprofen, and then sometimes we might switch to a lower intensity stimulation if we really need to. The serious side effect of TMS is, of course, a seizure. And the potential risk factors include sleep deprivation, polypharmacy of certain medications, and as we mentioned before, certain neurologic conditions. There's no association with the medicine bupropion in seizures. The rates of seizure risk are still very low. It's 0.04% for the RTMS device we use, and then for the DTMS, that's the one with the helmets, it's about 0.08%. So with the tolerability and side effects, we look at the history of depression symptoms, we look at the number of medication trials. That's how we help choose a suitable patient for TMS. When do you want to avoid it? No surprise, a history of seizure or metallic objects within 30 centimeters of the coil. There was some thought that TMS could help with cognition since there's no cognitive side effects. The meta-analysis showed that there wasn't that much benefit to cognitive activity, even though there was some improvement on this trail-making test here. Now, what if TMS doesn't work or help? Well, that's understandable. The success rate for TMS for patients with depression is between 30 to 64% of patients. In a complex case, we might consider, again, those therapeutic neuromodulation options, DBS, vagus nerve stimulation, etc. But it's not surprising here at SunCloud, if TMS doesn't work, we'll be looking at Spravato, the esketamine product. And then there's a lot of TMS applications in the future here beyond depression, and that's just a few of them for OCD, smoking, PTSD, as well as pilot studies for autism, mania, and other anxiety disorders. Now, quickly reviewing these ketamine and Spravato controversies and challenges. As I said before, here's Matthew Perry, and that shocking death last year basically involved physicians, not just the drug dealer, but these different physicians, including Dr. Plasencia and Dr. Chavez, writing fraudulent prescriptions who then gave that to Perry's assistant. It really showed some collusion, if you will, in contributing to this man's death. But on top of that, what we saw, and this is an article in the New York Times from 2023, was that during COVID, when rules between the states kind of fell, ketamine prescribed from fly-by-night ketamine clinics became a new frontier in telehealth. In particular, with rule changes in 2020, this at-home ketamine industry appeared overnight, and you got companies like Discreet Ketamine sending that, ordering it online and sending it over the mail to people who may be using or even misusing the product. And I think this just really summarizes where we're at right now, that obviously using Spravato is a regulated product, and that's why it's one of the reasons that your insurance will cover it. But a lot of ketamine is still available through a lot of other sources. Now, ketamine effects, short versus long term, are very noticeable, and here's a whole bunch. Some of people have depersonalization, derealization, even seeing God or having a near-death experience. Some of the long-term effects when ketamine is abused includes things such as depression, but also problems with regular ketamine with urinary tract dysfunction. We don't really see that with Spravato. Some of those addiction symptoms and effects, you can see them right here. So I'll just list them for you, and the physical effects, as well as mental and cognitive, and certain behavioral and social consequences. So with that, it's not for everyone. And here are the reasons. You might not be ready for that experience. You don't have the social supports to help support you as you get exposed to the chemical. It might have side effects you don't like. And of course, if your insurance doesn't cover it, it might be expensive to have the proper out-of-pocket costs for correct treatment. Now, psychedelics with therapy, I just want to mention this really quickly. We see that both with psilocybin and most recently with MDMA or ecstasy. Future goals. There was a big study that I referred to using MDMA for PTSD amongst the veteran population. Unfortunately, a couple months ago, the FDA said that study had a lot of flaws. Bias had seeped because participants and therapists were readily able to figure out who got it versus placebo, and also significant increases in blood pressure that could trigger cardiovascular events. So we're still not there with MDMA, but it's still on the horizon. And then ketamine-assisted psychotherapy has a number of different uses. Again, severe treatment-resistant mood disorder, depression, substance use disorder, behavioral addictions, chronic pain, PTSD, and other anxiety treatment as well. With that ketamine therapy, you start with a preparation session with your therapist. It moves to a medication session where you receive the medication under medical supervision. And then what's interesting is you have these integration sessions where you and your therapist will actually process what ketamine administration and the insights that you make are like. Finally, ketamine is still at the bottom of a lot of psychiatric decision-making. And as you can see here, most of it is all these other medicines, but only in this Florida guideline, you can see, is ketamine at the very bottom there. And so we're hoping one day that ketamine may not be the last resort after months of treatment. So with that, again, I apologize for the time here. Time for questions and answers. Thank you so much.
Thank you so much. We do have a few questions that have come in. The first question is there any success with these types of treatment with bipolar disorder?
And the short answer is yes. We've actually treated several patients when tweaking their diagnosis, both with TMS and I think with Spravato as well, when the particular depression phase of bipolar disorder was significant for the patient. So yes, it is able to treat bipolar depression symptoms, but right now insurance does require it for a unipolar depression diagnosis. As I said, we sometimes will tweak that.
Thank you so much. And can you talk a little bit about the effectiveness of these treatments with OCD in particular? Is it the same as other disorders or anything different?
Well, that's a very good question. So right now, we're not seeing a lot of psychoactive agents for OCD quite yet. But with TMS, as I said, two or more devices are approved for OCD. Usually with OCD, along with the treatment, the patient will have what's called provocation therapy. And so before we actually stimulate the patient, they are provoked with one of their OCD triggers, and that's part of OCD therapy, of course. But the response has been pretty good. OCD historically has a very modest treatment reaction. Patients who are on antidepressants for OCD are usually on twice the maximum dose of those medications. And as I said, we've used deep brain stimulation for a lot of them, but that's very invasive and very costly. So right now, we haven't really been doing it yet at SunCloud, but we're hoping to do that in the near future in cooperation with OCD therapists. But yeah, it does represent a very potentially powerful tool for people with really bad OCD.
Amazing. All right, we have a few more. What is the effectiveness of Spravato versus ketamine infusion therapy?
You know, there is some data out there, but I would say it really depends on the individual. I think the bioavailability of ketamine is 100%. So you could say that as it's completely uptaken by the body, since it's administered intravenously, it could be considered maybe a little bit more active more of the time. I think the problem with ketamine versus esketamine is several-fold. I think first, the esketamine has a slightly less intense effect because the bioavailability is a little different. Also, it's a different product. So esketamine is just that left-handed molecule there. And because of that, we see it being tolerated, I think, a little bit better, especially this dissociative side effect. Most importantly, though, esketamine has not been shown to cause a lot of the physical side effects as regular ketamine. And most notably, that is interstitial cystitis. That's usually the main physical problem that you run into when people use ketamine or abuse ketamine. So they each have their pros and cons, but I think it really, at the end of the day, depends on the patient.
Okay, moving on to the next one. Let's see here. I don't want to miss anything. Okay, is there any current information on the effectiveness of these methods with patients with dementia?
I was just talking to Anthony about that just a few minutes before, and there is some data that's emerging. Again, dementia is often treated by lifestyle modification, and then we have several categories of medications, acetylcholinease inhibitors, NMDA antagonists, some of them that have a very similar action to medicines like ketamine, for example. But in terms of its wide-scale use, I myself don't have the exact data, but there is something interesting to say, especially with neuromodulation, being able to affect the electrical signaling of the brain. If by doing that, it can sort of change some of the conductivity of the brain, there is thought that it might decrease the speed and the progression of things like dementia. So even though we don't have a lot of hard evidence right now, I tell folks to stay tuned.
Okay, we have two more, so we'll see if we can get them in. What about someone with MDD, anxiety, OCD, PTSD, and smoking? Is a combination of therapies used?
Right now, I would say yes, but it is done in sort of focusing on the bigger fish first. I think, like you were saying, with MDD and smoking cessation and OCD, a person could use a DTMS device like the BrainsWay device and receive treatments with different helmets for different diagnoses. But at the same time, I think, a good treatment strategy would involve medication management to help, as well as intensive or multifaceted psychotherapy as well. So my short answer is yes, we can treat somebody with multiple things, but usually using multiple therapeutic and medication tools, as well as the neuromodulation devices as well. Yeah.
Okay, thank you so much. And finally, we'll close with this question, circling back to bipolar disorder. Is there a risk of any of these treatments triggering a manic episode?
I would say that there was some concern with the neurostimulation of TMS contributing to the emergence of a manic episode. We know that there is some literature suggesting that when you give a patient who has bipolar disorder, say a unipolar antidepressant, that there is some risk of unmasking a manic episode. So I think, yeah, there is still the same concern with something like TMS. I don't think as much as a risk with ketamine or psychoactive agents, but you never can tell. Every brain is different, and so there could be a small set of patients to whom the certain chemical changes of ketamine or a psychoactive agent might be triggering. So so far so good, but definitely I can't say with 100% certainty there wouldn't be any triggering.
Thank you. Wow. I want to thank you both for being here and for this informative session. I want to remind our audience that No Shame on You presentations are for informational and educational purposes only and not a substitute for professional advice, diagnosis, or treatment. Always seek the advice of your own mental health professionals or physicians or other qualified mental or health professionals with any other questions that you may have. And just thank you. And you see the contact information for SunCloud here, for Dr. Anandappa. And I did put into the chat, if you have 60 seconds, please take a moment and fill out that survey to make sure we're hitting the mark and to report back for our funders who help make this possible. Our next Feed Your Mind next month is coming up really quickly. It's on November 7th. It is called Simplifying Complex Trauma. I put the link in the chat if anyone wants to register. We're partnering with a really wonderful organization called Skyway Behavioral Health. And with that, I want to thank everyone for coming. Have a good week. Happy Halloween if that's your jam, and enjoy some good sugar, and have a great day, everybody.
Thank you.
Thank you.
Bye-bye. And we are recording the session, so I'll send that out in a week if anyone wants to review anything. Take care.
Thank you. Bye.